Good evening, everyone. I'm Emily Akhtarzandi, Managing Director of Atlantic Live, and we're delighted to welcome you to the next Moonshot, an Atlantic exchange on heart disease. Heart disease is the leading killer in the United States for both men and women, claiming 600,000 lives a year. Additionally, the CDC estimates that 28 million are living with some form of heart disease right now. With this number of Americans affected, why haven't we made progress in lowering these numbers? And with so much attention on cancer and other diseases, where is the Heart Health Moonshot? How can medical professionals, pharmaceutical companies, and patients rethink heart disease treatment and prevention in constructive, innovative, and data-driven ways? So this evening, we'll hear from leading doctors, researchers, and patient advocates who will share their perspectives and new ideas about heart disease, all with the common goal of creating a heart-healthy society for generations to come. And now, we're here to bring this conversation to life. Before we get started, I want to take a moment to thank Amgen, our underwriter, for making this event possible. We're very grateful for their support, and you'll hear from them shortly. A few housekeeping notes. Please silence your cell phones, but don't put them away. We're on Twitter at Atlantic Live, and we hope you will join the conversation using the hashtag ATLX. And we want you in this room to be a part of the conversation, so we'll leave time for your questions after our speakers. And now it is my pleasure to welcome up to the podium Dr. John Tsai, Senior Vice President, Global Medical and Chief Medical Officer at Amgen, for a few opening remarks. So John, the floor is yours.
Thanks, Emily. Appreciate the comments. My name is John Tsai. I'm the Chief Medical Officer for Amgen. And let me just start with a couple of remarks, and let me paint a broad picture around cardiovascular disease. We've seen significant improvements in overall healthcare in the last century, and those improvements continue. But one of the outcomes of the improvements is that there's been an explosion of chronic diseases. And that chronic disease, as we think about it, is a culmination of a couple of factors as we think about chronic disease over the last 20, 30 years, and as we project forward. As we project forward, you can think about the increase overall globally in the number of individuals in the middle class, as well as the increase of population of individuals who are over the age of 65. In fact, in the United States, every single day, 10,000 people are becoming greater than 65. And this is the largest population and will roughly double between now and 2035. And in fact, one of the chronic diseases that we talk about is cardiovascular disease, which we will focus our attention on today. And it is, as Emily said earlier, it's the #1 killer of individuals and takes 1 out of every 3 lives in the United States. For 30 years, we saw an improvement based on advances in healthcare in terms of improvements in cardiovascular disease. However, in 2010, that curve started to change, and we've not seen improvements in cardiovascular disease since 2010. These are not statistics, these are patients, and we're beginning to fail them. And I actually think about an analogy of what happened just this past weekend when I received a phone call from my college roommate. He gave me a call and said that he began to have chest pain and had to be rushed to the hospital, and he had to get 3 stents, and asked me, why did this happen and what is the next course? And I think every one of us could relate to that story because you probably have heard that story from someone that you know. While others are moving away from investigating cardiovascular disease improvements, we at Amgen continue to explore areas where we could advance the science and understand improvements in overall healthcare, particularly with a focus in chronic areas such as in cardiovascular disease. We look at the genetic basis for improvements, and we continue to explore when people are moving away from this area. For us to be successful, however, we need a system that actually rewards innovation. So today is an opportunity for us to galvanize the broader community in terms of working together. We're exchanging ideas, asking each other questions, and figuring out ways how we can actually bend the curve in the right direction for cardiovascular disease. And for that, we will actually solve a problem for all patients. Thank you.
Thank you, Dr. Tsai. And now let's jump in. Please welcome to the stage Dr. Jennifer Robinson, Director of the Preventive Intervention Center for the College of Public Health and Department of Epidemiology at the University of Iowa, Dr. Ajay Kirtane, Director of the Cardiac Catheterization Laboratories for New York Presbyterian Hospital, Columbia University, Irving Medical Center, Danette Smith, the President of Mended Hearts, a patient advocacy group and peer-to-peer support network for those living with or caring for someone with heart disease, Dr. John Gordon Harold, Clinical Professor of Medicine at Cedars-Sinai Schmidt Heart Institute. And here to lead our conversation, please welcome Atlantic staff writer Olga Kazan. So Olga, the floor is yours. Thank you.
Thank you. Thank you, guys. So we're here to talk about a very important problem. Again, one of the leading causes of death in the United States. And actually, heart disease is going up in some parts of the country despite all the progress that we've made, despite the fact that people can now survive heart attacks and all of the other advancements. So we're here to talk about what we can do about that. So I guess just to kick things off, if each of you had a magic wand and you could change one thing, whether it's a policy, whether it's something in the healthcare system, whether it's a new type of pill or device to help improve outcomes or reduce heart disease, what would it be?
Well, to start, I think you have to focus on the social determinants of health because you can make such a tremendous impact on changing behavior. And you can start with hypertension as a risk factor. You can start with lipid management, diet, obesity, and so on. But I think focusing on the social determinants of health, communication with patients, recognizing that this is a global issue, and starting at one patient at a time.
I would like to see better access to treatments, drugs, whatever device, whatever it is, for people, because I work with the general public, and I understand the trauma that they go through in trying to access their drugs. So I would like to see it made easier for a patient to be able to access what they need without going through a lot of pain and suffering, if you will, from whatever source.
Yeah, I mean, to build upon that, I think the access thing is such a critical issue. It's so hard to find a doctor that you know is good. Just think about if your family member got sick or otherwise, I mean, what do? You call up somebody who knows somebody and you try to get them to see somebody that way. So I honestly think that in some respects, just sorting that problem out and trying to figure out, is there a way to categorize people and know that you can trust a certain physician or otherwise would be a big help for a lot of patients.
Well, we've spent quite a bit of time being frustrated by our lack of progress in terms of the obesity epidemic, and now heart disease rates are going up even in younger people. So we've proposed a trial called Cure Athero. So curing early atherosclerosis through the National Heart, Lung, and Blood Institute. And so it'll be the first in-human trial to really try to see if we can replicate a lot of the animal data that's come out over the last several decades, where if you take animals and you give them atherosclerosis by raising the cholesterol in their diet, and then you take the cholesterol away, early stages of atherosclerotic plaque you can completely dissolve. It completely regresses and the artery returns to normal. If you wait till more advanced plaque forms, you can stabilize it. But the problem is we're treating people way at the far end with advanced fibrotic calcified plaque we can never make go away. So we want to find the sweet spot earlier, and the idea is to take obese younger adults with risk factors and lower their LDL to about 20 to 30 for 3 years and see what happens to the plaque on their CT angiogram. So it'll be kind of the first in human to see if we can document massive regression of earlier stages of atherosclerosis, because the hope then is as we if we can establish that this works, who to do it in. And then you could treat every 30-year-old with intensive lipid lowering, induction therapy for 2 or 3 years, and then atherosclerosis is a disease of decades, so then they can, retreat them, intermittently or long-term suppressive therapy. So it's kind of this wild new paradigm, but we could actually, within a generation, cure atherosclerosis, which means we prevent all heart attacks and strokes from atherosclerotic causes. So I thought that was kind of a good moonshot idea. Yeah?
Yeah, absolutely, yeah. That's a great moonshot. And I'm wondering though, anything like that, so getting someone to take those medications then after the fact, getting even people to take statins, you guys were talking about how a lot of times that's difficult even for people who have had heart attacks. Can you guys weigh in on kind of why is it so hard to get patients to follow a regimen, whether it's diet and exercise or whether it's, taking something like statins?
Well, I can begin. A lot of it is cost and access and communication.
Yeah.
And talking to a patient, in a one-on-one relationship and explaining why they need to take the medications, what the indications for, what the expectation is, and so on. And we failed in many respects to do that on a consistent basis. So in my own institution, Cedars-Sinai, there's a study which will be presented at this meeting, the Los Angeles Barbershop Study, which looks at approaching African American males with hypertension in the community. So sort of a T4 translation, population health, dealing with hypertension at the point where these individuals often get the opportunity to get checked. So who's doing the checking? The barber. And what was demonstrated in Dallas by Dr. Victor a few years ago was a significant improvement in blood pressure readings, improved compliance and understanding. It's about education, communication, and outreach. And it talks about the importance of reaching out to the community and being culturally sensitive to the population that you're dealing with.
Yeah, I think that's critically important. There have been studies that show that if you prescribe a medicine in the doctor's office, the likelihood of the patient actually filling the prescription is about 2/3 or so, and then the likelihood that they take it the way you prescribed it, another 2/3. Just think of the last time you had a cold or somebody gave you antibiotics for something. Did you really take all 7 days of it, or did you kind of take 5 and then you felt okay and it was all right? So that's the challenge. I mean, we have to spend time in the office doing that, and then there have to be follow-on programs after the office visit to ensure that they've filled the medicine in the pharmacy, that they understand that when they get on the internet and read that laundry list of side effects, that that's really rare to actually happen and there are actual benefits to it. So all of that is really important.
And you said you've seen studies with the nocebo effect actually in the brain, right?
Right. A lot of my work is in statins. I was the vice chair for the 2013 ACCHA statin guidelines. And the problem is why somebody has a myocardial infarction, discharged on a TOR of 80, according to the guidelines, within a year, half of them are not taking a statin at all. What's the disconnect there? And so another thing that we're just in the early stages of is, why don't we approach people's willingness to take medications like we did for example, smoking? We've turned smokers into these social outcasts. It's like you're a pariah. There's something, it's like we changed the social norms around statins, or around smoking. Why not change the social norms around statins we've done some pilot studies in actually Hispanic mothers, and went amazingly well. It was I was kind of shocked. And so we were excited about it, but there's ways to message things so that people understand. I'm sorry, we live in a terrible obesogenic society. People have to take drugs to combat it if they want to live healthy, productive lives. And so just how do we go about changing that? I think that would go, and it's not just, statins are the most obvious example because there's all this negative statin hysteria, but it's like a mindset, right? I don't want to take a pill, I want to do it naturally. All those sorts of attitudes I think we really have to overcome.
How did you change the messaging in the Hispanic women's study?
We talked about mothers taking care of themselves and the importance of healthy diet and for the family and active lifestyles and all sorts of things. It was a very positive message, really. And part of it was just to go get your cholesterol checked because we also want to treat people with FA, familial hypercholesterolemia and things like that. But also, a lot of them did have, risk profiles that did need some sort of intervention. So, get your risk checked, get your cholesterol checked, those sorts of things is a positive activity.
But speaking from a patient standpoint, it's extremely hard to comply. It is so hard. There are side effects. You get tired of the side effects. You can't do anything about it. And it's easy just to stop taking the medication. I've seen it so many times. I volunteer in the cath lab at my local hospital, and I have seen the cardiologist come out and tell the spouse that they had to put in a stent and that the patient was going to have to be on an anticoagulant for a while. And they're nodding yes. And then when they walk away, the spouse says, "She's not going to take that." And I'm going, what? It's crazy, but it is difficult. And I've always, in my mind, compared it to, I'm also a cancer survivor, so I compare my thoughts with that illness as well. But with cancer, people are so frightened by the word. And with heart disease, they're not.
Yeah.
It's hard to eat a good diet. It's so much easier to run by the drive-thru and get a Big Mac or whatever. But it's really hard, and they just don't want to do it. Same with exercise; it's just difficult. So if we could start it from early childhood, and we wouldn't need something at age 30 or whatever to stop their cholesterol. If we could just stop it when they're little and get them excited about eating healthy foods and things. I know that's a big moonshot wish, but it makes sense. If we could stop it before they need the drug, then all this doesn't matter.
Yeah.
I think it gets back to the concept of the entire care team. And George Bernard Shaw said the problem of communication is the illusion that has occurred. And frequently, communication has not occurred, or if it's occurred, it has not been understood or implemented in terms of what was recommended. And the challenge is compliance, and why do patients not comply? Sometimes it's behavioral, sometimes it's cost, sometimes it's embarrassment of not being able to afford some of the medications as well.
Yeah.
So some of our patients will come in and say they're taking it, but it's obvious by their blood pressure or their cholesterol levels that they're not. Then you have to just have a high index of suspicion, and then work with your team to correct that as much as possible.
So that's how the communication breaks down one way, but there's also communication breakdown the other way. I thought it was interesting what you were saying, Ajay, about how it's actually really hard to even tell how much patients are complying. Can you talk about some of those challenges?
Yeah, John said they may say that they're taking it, but we always teach the residents, call the pharmacy and ask. But it's interesting because I almost think that, and this is an IT problem that so easily could be solved. If there was a way to, have triggers, automatic triggers to know when the medicines were being filled, or if they were, prescribed to the wrong pharmacy. So many different things that just could be solved with an IT solution. And there are programs out there now that alert patients it's time to take your medicine or it's time to do X, Y, and Z. Compliance is such a huge issue. I think C. Everett Koop said that drugs don't work in patients that don't take them. So it's just, you can prescribe all you want, you can think you've done all these erudite things and diagnoses, but if there's no solution on that other end, it's really hard to implement change.
And Donna, so maybe you try to ease some of these communication breakdowns through your work. Can you tell us a little bit about first your personal story and then how you came to be working with Mended Hearts?
Sure. I was born with a bicuspid aortic valve, later developed into aortic stenosis. I found out when I was in my late teens that I actually had this condition. I had been treated for asthma from the time I was born until I was in my teens. So it was quite a surprise. I had my first open heart surgery to replace the aortic valve in 1988. I had complications and had to go back into surgery a couple times more. I then had supraventricular tachycardia. I had ablation for that. Then I had breast cancer. I went back about a year later after that. I found out that I had an aortic aneurysm. I had surgery to repair that and replace the aortic valve again with a mechanical valve. Back in 2009, I started having some issues again, and I was diagnosed with my valve failing again, which was just really, mind-boggling because you think an aortic valve, a mechanical valve is supposed to last a lifetime, and that's what I was counting on, but what had happened, they think now, my cardiologist thinks now that the radiation that I had for my breast cancer caused damage, and my aortic valve, the mechanical valve, one side clotted shut. So I had emergency surgery they did an apical aortic shunt with a pig valve in the end of the shunt that bypasses my mechanical valve that's still there. But as crazy as I am and as difficult a case as I am, about 6 weeks after I had the surgery, I went back in for a cardiac MRI, and the surgeon came out and said, well, your mechanical valve is working 50%, your pig valve is working 50%, so we got blood going this way and blood going that way, and you're just a mess. So I got involved with Mended Hearts after my first heart surgery. I was so amazed at the difference that a visit from a fellow patient could have on me, because I didn't know anybody who'd had heart surgery. And a man walked in the day before my surgery and said, I had the same surgery 2 years ago. And he was playing tennis, he was playing golf, he was doing everything that he ever, was doing before. And I thought, wow, it's cool. I can do that, because I'd always been very active, and I went back to being that. But I've worked with Mended Hearts since 1988, and I'm now the national president. I love what we do. We started 10 years ago working with children born with congenital heart defects. So we work with patients from even before birth to the end of life. So we cover the whole spectrum of the lifespan. I love what I do. Everyone who has a part, and we go in and visit patients' bedside, and they've got that deer in the headlight look, and you know it all too well, and you can reassure them and comfort them and encourage them, and it's wow, you're walking on air when you come out of there. So that's why I do what I do. That's what Mended Hearts does.
Wow.
Thank you.
How many are there of it's not volunteer, right? You get
No, it's volunteer.
Oh, it's volunteer. Oh, wow.
Yes,
How many
volunteer?
Wow.
We have about 20,000 members. We're in about 300 hospitals or so. We see about 20,000 patients a year bedside, and now we're doing visiting on the internet. We get a lot of we do Twitter, we do anything that we can reach a patient. It's what we're doing now, and it's amazing.
From the doctor's perspective, what impact does that have on patients?
Well, that's an extraordinary resource to physicians. At Mended Hearts, I had the privilege of speaking at their annual meeting a couple of years ago, and such an engaged group of individuals I've not seen. It's just an extraordinary group of patient advocates who really make a difference in recovery where they function. And having a patient advocate to visit you after surgery, or a pacemaker, or after a cath can make a big difference. Also, a big difference in understanding about need to comply with recommendations with drug regimens and so on that are quite complicated. And there's nothing better than a peer telling you what they've done and how they've lived through it, and they're there as a champion or a patient advocate. So kudos to Mended Hearts.
Thank you.
Yeah, I couldn't agree more. And beyond, advocacy in those ways, it's just the whole care team. So the nurses, I always joke that we can write the orders, but the nurses are actually taking care of the patients. And nurses, social support staff, and everybody else, you have to be humble enough to recognize that you could be the nicest doc in the world, but there's a different way of connecting with people that have shared experience.
That's
and
right.
I think your story is amazing, and you look great, by the way.
Thank you.
Well, I wanted to pivot a little bit and talk about what we're seeing globally. And John, maybe you or anyone else who kind of follows this can weigh in. But I'm so stunned whenever I go report abroad, and all these places where we used to hear there are starving children in X. A lot of children there might be starving, but a lot of them also are obese. A lot of heart disease in some of these developing areas of the world. So why are we seeing that all of a sudden?
Well, there's a worldwide epidemic of noncommunicable diseases, and heart disease, of course, has the highest associated mortality. The United Nations took this on in 2011 as the second health-related issue. HIV was the first, and they had a high-level conference of heads of government at the United Nations in 2011. The next major high-level conference is scheduled for the General Assembly meetings in the fall of this year. And NCDs really are a huge impact on the economies of nations. In India, for example, highest rate of increase in terms of obesity, in terms of diabetes, in terms of heart disease. This has an impact on both the nation's economy and the global economy. So that's why nations are paying attention to this, and heart disease plays the biggest role at the moment. And heart disease, if you look at Europe and India and other parts of the world, you're seeing it at a much earlier age than we're seeing in the United States. So you'll see in Eastern Europe and parts of Russia, heart attacks are fairly common in the early 30s. And life expectancy is actually much less than in other parts of the world. So I think it's a big challenge. NCDs are part of this. The Sustainable Development Goals are part of the UN mandate. But if we don't attack heart disease on a global basis, it's going to lead to significant economic issues.
Right, I mean, it's been interesting traveling around the world over the last couple of years. You know, we exported all of our jobs to other countries, apparently, like to Asia. And man, Asia's amazing. It's developing. They have better cities than we do, brand new cities. So all that money is going to buy Western lifestyles. And so it really, health-wise, kind of looks like we did in the 60s when, 45% of men smoked and, there was lots of, animal products, except now they have Coca-Cola and stuff like that. So that's why we're seeing it. And then on the other side of that, there's nothing to counterbalance it. They don't treat hypertension. People are smoking. The whole cholesterol. Nobody uses statins. So we've had a 70% decline in cardiovascular mortality over the last 30 or 40 years, and they're still up here. So I think as all the organizations are working to try to implement what we already know works in terms of preventing that from continuing. I mean, people are dying. I mean, it is a huge impact when people are dying in their productive years and leaving families behind, and it's really quite a huge problem.
And the other point I'd make, we're here at the American College of Cardiology meeting, and right now there is a global health meeting ongoing right now with members of our Assembly of International Governors representing the various countries across the world. And again, the focus is on global health. What can we do to make a difference? What is the new idea for, what is the moonshot for global health? And again, our colleague from Brigham wasn't able to attend, but one brave idea, I think, is the beginning of a new approach to looking at these issues. A $75 million investment in looking at what is the primordial causes of heart disease and how can we make a difference. And that will have global implications.
And that's for research or for?
Research.
Oh, okay.
Research.
Oh, wow. Has anything, I'm just curious, has anything worked to stop the onslaught of fast food companies in low-income countries or here?
Well, we limited tobacco is such an illustrative public health thing because we kind of, 20% of Americans still smoke, but on the other hand, we've banned tobacco products in lots of venues, and now that's gone overseas where the regulations are just emerging overseas in terms of tobacco regulations. So it's kind of the same sort of thing.
I mean, it's a controversial statement, but some would argue that the reason the settlement happened the way it did here was because the business was going to be there in Asia and everywhere else. And so it's a challenge. I have folks that take care of people in India. People have heart attacks in their 20s. It's not uncommon. Right. And I think it's a big, it's a potential big opportunity though for preventative development, because if you did have an agent like you're talking about that you could arrest at an early age, or even something that was longer acting. There have been efforts to try to incorporate what were called polypills, where you combine multiple agents into a single pill and be able to deliver it. The other thing is that despite the actual construct over there sociologically, a lot of them have cell phones and they respond to text alerts and that sort of thing. There's a lot of research has been going into, for instance, doing maternity care via SMS in India, for instance. So I think those types of innovations, may not be that much cost up front, but can affect a lot of people in a very positive way.
Yeah. I want to switch to talking about public policy and what public policies you'd like to see implemented or changed, either at the local level, the federal level, state. And I know you're all coming from different places, so that would really make your lives easier, would reduce heart disease, would improve outcomes, any of the above.
Well, I think you can begin with all the identifiable risk factors. So in the state of California, very early on, we lobbied to ban beverages, sugar beverages from schools. And that was one of the early accomplishments, and that's sort of occurred in most parts of the country now. If you look at smoking regulation, most of California now, in terms of public areas, is smoke-free, and that's a big issue. The Heart Association will only have their conventions in smoke-free cities. Oh. So you can make a political impact through advocacy, through economic decisions such as the Heart Association has done with smoke-free cities and so on. I know you can talk about some of the other risk factors you can do from a public advocacy point of view.
Well, as I'm sitting here thinking, if I could only have one.
Choose wisely.
It's kind of a gnarly problem. I think having a better healthcare, universal healthcare system, but again, going to other countries where they do have single-payer healthcare, and there are ways to do it that don't offend Republicans as much, but that everybody has a right to healthcare and it can be done. And drug prices are negotiated directly with the drug companies, and you get rid of all these middlemen and corruption and all this back-end negative incentives, and to me that would be probably a big advance. I'm not going to advocate any policy.
That's a good one, no?
There's the talking about Medicare for all, and those sorts of things are on the table. So we'll see.
For sure.
Yeah, for me, I think that I wish we could have some way of reporting outcomes and quality that was meaningful to patients. I'm an interventional cardiologist, so for me, a lot of procedural reporting in New York State, for instance, is procedural based. So what is your rate of having somebody die after a procedure, 30 days? But what's interesting is that if we actually look at the reasons that people might die 30 days after a procedure, they very much have nothing to do with the procedure. They just happen to be that the patient was too sick to have surgery or anything else. And so what we see a lot is people avoiding doing procedures for that reason. Because we only report on what happens after a procedure, but we don't report on the 10 people they didn't do a procedure on because they were afraid that they were going to have an adverse outcome. And so this whole issue of underuse is something that I don't think we talk nearly enough about in our society. And there are people who don't get therapies that they ought to get simply because nobody's actually measuring it. And when they then have a bad outcome and they die, someone blames it on their obesity or their cholesterol or anything else, but nobody gets at the root problem, which is that ought to have been taken care of in the first place. So from a policy standpoint, I wish we could focus more on these issues of access and underuse more than simply let's just measure outcomes after procedure. We have to be smarter than that.
That's interesting.
And I'm more interested in the advocacy part of it, and we've just gotten involved in that at Mended Hearts. We try to tell our patients, you've got to be your own advocate. You've got to stand up for yourself. You've got to make your voice heard, and we're trying to do that. And one of the things that I would like to see addressed is more funding for research for congenital heart defects. There just isn't that much out there. And so we've got parents, the little ones can't speak up for themselves, so their parents are begging for information, for research, funding, so that they can find out what's causing these defects and what can be done to prevent it. It's so sad to see a tiny little one born with half a heart, and see that little one grow up and have to go through numerous surgeries, and it breaks your heart. It really does. And I've seen one little one, he's a young teenager now, and his thing was to play baseball, and he did. It's really something that needs to be looked at more, and so I encourage that. If that could happen, that would be my wish, that there would be more research for congenital heart defects.
Yeah. Did you have a second one? No?
I was going to illustrate an example of thinking differently. So Michael Bloomberg, who's a global ambassador for the World Health Organization, and what he did in New York City when he was mayor in terms of smoking cessation, in terms of menus, calories on menus, polyunsaturated fats and all that, and how one person can make a difference locally and then have a global impact. And I think Michael Bloomberg is one example of that.
Yeah, absolutely. I'm going to take questions from the audience in 1 minute, but first, Ajay, maybe you could tell us a little bit about both, variability of care and personalization of risk. So 2 big terms, but what do they mean?
and we've touched on it a little bit, but it's similar to if you come into the hospital or you see somebody in the office, and you just, as a patient, you don't know what therapies you're going to be offered, and it may be totally different just based upon the opinions of who it is that you happen to be seeing. And I think that there are ways to sort of, determine what are the best ways. There are guidelines for that, and there's practice initiatives and otherwise, and a way to sort of regularize that, but then to follow that with outcomes that could be perhaps done through machine learning or other techniques to then see, well, did that really make sense? And then you could even go further and sort of say, well, for this person, we need to do this, but for this person, they're a little bit different, we need to do something else. And I think this whole delivery of care aspect is something that we don't focus on. We just kind of send docs out, nurses out into the world and just say, here's your training, practice. And it's just much more complex than that.
Yeah. Any questions from you guys? We're going to have mic runners coming to you, so don't be shy. No questions yet? I see okay, one question back there. Or, I don't know who asked first.
You had one? Oh, yeah.
Right here.
You next.
Is she going in? Sorry. Hi, my name is Pushali Mukherjee from Bristol Myers Squibb. One of you mentioned, patients being more afraid of hearing about adverse effects of drugs and hence probably choosing to withhold treatment. What can we collectively do for patients to understand that adverse events are rare and the benefits much far outweigh that? Because that's common across all socioeconomic and education levels.
So I can begin to address that. So the American College of Cardiology has a patient portal, which is called CardioSmart. And on CardioSmart, there are a variety of patient education materials that talk about topics, high blood pressure, high cholesterol, and they're very simplified devices to give to patients as part of an education issue. We also have iPad-driven education that patients can log on to and review. Mended Hearts has a very similar opportunity. American Heart Association does. So I think the issue is education, 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 because most of the side effects, for example, with statins, in my experience, most patients can tolerate statins with some education, and the challenge is separating out the aches from the true myositis or other complications. But at the end of the day, if it just takes some insistence and some working closely and leveraging your healthcare team. It's all about communication, as I said earlier, and the best part of our team are our nurses, our nurse practitioners, and they have probably the biggest impact in patient compliance in my experience.
I mean, I think an easy solution, though, honestly, is the FDA regulation that you have to list every laundry list item of side effects. I mean, is that really that helpful? I mean, we understand that you don't want, we don't want companies to over-tout the benefits of their individual medications and the like. But I honestly find that's like the biggest source of frustration because, if there are a lot of good things that some of these medications do, like prevent heart attacks, prevent strokes, and prevent you from dying, I mean, that ought to be kind of trumpeted with the same amount of bandwidth as the laundry list. So.
Right. And that's what we tried to do with the guidelines, because we said there's this very large and strong net benefit proven in multiple trials that statins benefit these patient groups and you must use them. And so I think that actually we're bending the curve. The national cholesterol levels are going down and statin prescriptions are going up because we actually had to convince the primary care doctors because the cardiologists, I'll just share a fun little project one of my students did. He looked at all the veterans, the entire United States revascularizations, and he looked at what the discharge medication was, and it's gone up for atorvastatin 80, and that's not the VA guideline, by the way, but kind of starting in the early 2000s, 80% of VA patients are discharged following a revascularization on atorvastatin 80. 80%. Cardiologists are getting it because cardiologists are used to practicing evidence-based medication. I think they have a more aggressive mindset too, But then they go out to their family doctor and they say, "Oh, my hair fell out," or just anything. Oh, and the primary care doctor says, "Oh, okay, well let's put you on pravastatin 10 milligrams, or just stop it." So I think we have to, when we make guidelines, and I will just put on my little guideline rant here for a minute. I mean, it's one thing for cardiologists to make guidelines, but you have to make guidelines that the primary care doctors, they have a different standard of evidence, and I think the hypertension guidelines are a good example of kind of maybe a failure in that regard, because you got to go to where they are at Because if you're a primary care doc, you're not just thinking about their heart, you're thinking about their intestines and their brain. I mean, you're thinking about everything. And so how do you pick out the most important things, what you absolutely must do? And I think that's something that you know, getting people up to speed on guidelines and things like that are good.
I mean, the one thing, though, to be fair, though, about the primary care docs is they're the ones getting all the phone calls. So it's easy for us to prescribe 80 of atorvastatin.
No, but they have to. But then they have to push back and say, well, no, let's work through it. You know. But and frankly, up until fairly recently, many primary care docs were very kind of therapeutic nihilists in the statin space. You know, they didn't believe in the statin. The doctor didn't believe in the statin evidence. So, you know, that's been a hurdle I think we're moving past, but all those things need to be taken into consideration.
This is a side question I have on that. Actually, has all of this stuff around like the, you know, unreplicated studies and the sort of, you know, there's been a lot of these questions about like science, how rigorous is it really? Are people p-hacking? Have you guys seen any of that as far as like patients being like, well, how do we really know that this works, you know?
Well, I think there are two sides to that story. So the first issue is the implementation of guidelines into practice. And what is the lag time for that? And you know, some people have argued the lag time could be up 10, 11 years. And that's true for a number of different drugs. And part of I think what organizations like Mended Hearts is doing is making the patient become the advocate for themselves. And they go to the doctor with information from Mended Hearts. Why am I not on a statin? Why is my blood pressure still too high? So I think you can flip the equation around. I mean, hand washing, you know, to prevent puerperal fever was described in 1847. It took 100 years for doctors to accept that hand washing was important. And when I was chief of staff at Cedars-Sinai, we started looking at what was the compliance of hand washing with physicians. It was ridiculously low, and that became, you know, one of the goals that we changed from, now it's almost 100%, but changing behavior is not simple, and part of it is, again, it's educating the physicians, but understanding how you translate guidelines into practice, and where is the point of care, and who is at the point of care. It's no good if the cardiologist gets it, you need the primary care physician or the nurse practitioner, whoever's at the point of care. The pseudoscience I see less of.
It wasn't really a question, but I had a couple of comments that I agree to a certain point that to compare smoking to heart disease or high cholesterol. But see, smoking affects everybody, race, age, anybody. Heart disease doesn't. My husband happens to be one of those Americans from Virginia that can eat anything in the world that I will say, oh my God, no way. And he can eat it, his cholesterol is 190. I can only look at something and mine is 250. So, you know, that's a big difference. And also, regarding the side effects listing, I think it's important. I'm a bookworm. By the way, I have subscribed to this like for 25 years. I used to stuck at this talk. But I read everything. I wouldn't take it if I wasn't able to read everything. So I am an educated patient, and I understand. I need to be here. I want to be here. I raised my kids. It was important to be here. I was diagnosed with high cholesterol when I was 30, and I didn't even think I had to go to the doctor. I had a fabulous HMO, GW in Washington, D.C., and I said, gee, I pay for that. I never go to the doctor. Never even met a doctor, so I'm going to do it. They called me again for a retest of my blood work, and it was sky high, 264, 30 years old. And I didn't even understand how serious was that at that time, because my family is not overweight, so, you know, you can't tell. So it became serious for me from that point on, because they wanted to put me on medication, but the doctor said, do you want to take it or do you want to exercise? And I said, oh my God, I exercise. I join a gym tomorrow, I'll do it. And I did. It kind of changed my life in a positive way that I became an exercise aficionado, and I have never stopped. And it's good, but I just celebrated a big birthday, and everything changes. It doesn't matter how much I exercise. It doesn't matter that I am a runner, that I do body pump and I lift weights. I can lift like 50, 60 pounds. And I am an instructor, an exercise instructor as well. But my cholesterol keeps on going up. I don't even smell a piece of cheese anymore. And it keeps on going up.
Well,
so it's about the pharmaceuticals, about the pros that are being offered. I understand that my hair used to be much nicer before the statins. Okay, I can deal with that. It's not that important.
Any responses to
well, as you're talking, and so, I mean, you have a whole series of 80-year-old women who present with their FH to the cath lab because they had healthy lifestyles, but they still ended up having cardiovascular disease. But I think what's really another point to be taken from that, and what we're learning from the genetic work, is that we all have different genes. Humans are predisposed to get atherosclerosis. We have mummies living hunter-gatherer lifestyles with atherosclerosis. So we're genetically predisposed. And so some really interesting work has come out recently. So they've taken people, we've got about 156 genes now. You can put a score together, a risk score for cardiovascular risk. And they divided people up into 3 piles. So bad genetic risk score, good genetic risk score. And it turns out that lifestyle cuts that risk in half, But this person still has a high risk and they still need to take a statin. This person dodged the bullet and certainly should do lifestyle. But I think as we get better about this and we can kind of better triage people for the intensification. And early in life, I mean, one of the things we'll learn in my Cure Athero trial is all those people we're finding in their 30s with plaque are going to have bad genes, and so that may be a group where we'd want to start with intensive therapy at a younger age than waiting. So I think all this is ahead of us, and we're not quite there yet in terms of, we still have a little bit more genetic work with, we need to know what, whole genome sequence, I mean, it's a little more complicated, but I think we're just at the cusp of that, and we can do more precision risk, but it's still a guess, right? A precision risk estimation, but at least we can put people in piles and say, well, you should really start the statin when you're 30, but you can maybe wait till you're 60. And so I think that's where we're headed.
So I think also it speaks to how do you do early risk assessment and what is the methodology to do that? And it's taking a history, it's understanding the family history, it's understanding what their specific risk factors are, what's modifiable, what isn't modifiable. And some patients will get, for example, coronary CT imaging. When that was done in mummies, for example, in several populations of mummies, what we found is atherosclerosis is ubiquitous in the history of mankind. So you image 5,000-year-old mummies and you see severe coronary calcification, both in Egyptian mummies, and you see hunter-gatherers from up in northern Alaska that were frozen that also have severe coronary disease. And you wouldn't have thought that population would have been at risk. No. And so these are all issues that we don't really understand the biology. As I said earlier, one brave idea is looking at what is the biology that predisposes people to atherosclerosis? What can we do at an early age to interdict, and what can we do to cure atherosclerosis? And I think the moonshot in this room is what is going to be, will there be a cure for atherosclerosis, which has been with us for thousands of years?
Hi, Chris Granger. I'm a cardiologist at Duke University, and I'd like to thank the Atlantic and this great panel for this great discussion. And I think another way to look at this is, I think it's the first year since 1917 that the life expectancy hasn't increased this year. And there seem to be these two factors. One is the opioid epidemic, and the other is cardiometabolic disease. And a lot of it is, I think, does also relate to diabetes and obesity. And I'd like to thank Danette, because I think the part of the moonshot really does need to focus on advocacy and patient advocacy groups. And like HIV and cancer have been so much better than we have in cardiovascular disease, because there's still, and I think the panel has reflected this, there's still so much that we don't know, where we really need more research and more investment into finding out how do we change behavior, how do we better apply therapies, how do we modify cardiovascular outcomes for patients with diabetes and address obesity and lipids and these other issues. So, thanks.
I would just expand that. George Mensa had an article in circulation talking about the Moonshot for Translational T4 research, which is really translating it to population health. What is the impact at a community level, a patient level, and where can you make a difference? And so I think that is a future direction.
You know, I would like to see cardiovascular patients as excited about surviving a heart attack or lowering their cholesterol as cancer patients are, especially breast cancer, women who've had breast cancer. I've been to the Susan G. Komen 3-day, my daughter ran in it, and I was amazed at, I mean, there was crying and hugging and people, strangers, and it was just the most emotional thing I've ever seen. And I thought, well, you know, I mean, it's more important to me that I'm surviving a heart issue than it was that I had breast cancer. While that's important, I would like to see people as excited about surviving heart disease as they are about cancer.
I have an anecdote, which is that I recently interviewed someone who's 33 and has heart failure. And I was talking to him about this among his peers. And, you know, I said, like, oh, your health issues, you know, in the course of the interview. And someone from his community was like, what are your health issues? Like, so this person has heart failure at 33, and it's not even recognized as a health issue, really. And I was talking to an expert recently who said that, you know, if you go to in the rooms of cancer patients, you have like the family there and flowers and, you know, kind of a lot of support. But if someone with heart disease or heart surgery, you don't necessarily see that. So
that's true. Yeah, that's true. And I would like to see that changed. I don't know how, but you know, I want to tell the world. I had my first heart surgery when I was 40 years old. I just had my 70th birthday. So I'm pretty darn lucky to still be here, and I'm excited about that. Yeah. Mm-hmm.
You know, I think one of the problems also, it's a problem with progress, is that, you know, we're so good at some of these therapies and doing them so fast now that, you know, if you have a heart attack and you have a stent, you go home the next day, the day after that, and so many people just sort of say, it's not a big deal, I was through the wrist, it was fine. But I think that really moving the ball out into the preventive paradigm and really trying to, you know, say, well, we've done some work, we've done cosmetic work, but we now have to treat the disease. And that paradigm is something that's so important to emphasize, not just to patients, but also at a meeting like this, to physicians, trainees, people who come to it, because it's great to treat somebody that way, but if you follow them in the office, it's when they stop smoking or when they start exercising again, they tell you they lost weight and their diabetes starts getting better and everything else. Those are honestly the more gratifying things if somebody's in practice for a long period of time than just doing a single procedure on a patient.
And I would say, you know, I think we have a marketing problem. I had an interesting talk given at this policy thing out in Washington I went to by the Sergeant Major of the Armed Forces. And so he's responsible for the health of all of the armed forces. And what he said was so interesting because this is a very kind of conservative mindset. It's not a bunch of, you know, it was really very interesting. So he said there are a couple things. One is we can't recruit enough people for our armed forces. We actually have a national security problem because we can't the young people are too unhealthy, they're too obese, and they can't be inducted past the entrance into the armed forces, and so it's actually a crisis. There's a report coming out about this. And the second thing they do is, so when they do get people, these young, you know, people 18, 19, 20 years old, terrible, terrible health habits, you know, they bring them overseas, you know, Afghanistan, etc., and they said they have to totally reorient them into living healthy lifestyles because they need to do it to be prepared to do their job, to, you know, function at the highest level. So I think we have to think about how we market what we're talking about, because often it's so punitive, you know, you need to do this, you know, you need to, you know, do all these things. So anyway, I think we're kind of changing. I mean, I think it'll be an interesting thing to look at. The other moonshot-y thing, I think, is the actually reinventing healthcare, right? Amazon, Berkshire Hathaway, and was it Chase Bank said, forget that. We're gonna start over. This is so broken. We're just gonna start over. So I think because of harnessing all this big data and all this stuff, and actually I think it's kind of an exciting time.
Yeah.
That's the key. Access.
Yeah.
I think it's so cool and the starting people.
Well, I think actually, so hopefully there'll be time for you guys to maybe circulate and possibly address some more questions, but I think that's our time. Thank you guys so much for coming, and thank you guys for your excellent remarks. Thank you.
Thank you so much, Olga, and thank you to all our speakers for this wonderful conversation. I'd like to thank our underwriter Amgen for making today possible, and all of you here today for joining us. And before you dash out, one small request. Everyone will get an email from me with a survey about today's program. I think we have hard copies in the room. We'd love your feedback. It means a lot to us, and I hope everyone has a wonderful evening and rest of conference. So thank you.